Okay, let's get started. Hello, everyone. I would like to welcome you all to today's medical grand rounds. Our speakers today are Dr. Lee Tynes and Dr. Angela Breidenstine. Dr. Lee Tynes is an associate professor of psychiatry at the Tulane University School of Medicine and medical director of Our Lady of Lake Mental Health and Behavioral Health Service Line. Dr. Tynes received his Ph.D. in clinical psychology from LSU in Baton Rouge and then completed a psychology internship and fellowship at McLean Hospital in Boston. He then earned his MD degree from LSU Medical School and completed a combined residency in internal medicine and psychiatry at Tulane University School of Medicine in New Orleans, a program he helped to establish. He later served as its program director for 12 years. In his current position as a medical director for the Mental Health and Behavioral Health Service Line at Our Lady of the Lake Hospital in Baton Rouge, Dr. Tynes teaches residents in psychiatry and medicine from LSU and Tulane. Dr. Tynes has over 50 papers, abstracts, curricula, and book chapters on topics related to internal medicine and psychiatry. He's a fellow in the American College of Physicians, the American College of Psychiatrists, and the Academy of Psychosomatic Medicine, and a distinguished fellow in the American Psychiatric Association. Dr. Tynes' presentation will be followed by Dr. Angela Breidenstine, who's a clinical psychologist and assistant professor in the Division of Child and Adolescent Psychiatry at Tulane University School of Medicine. Dr. Breidenstine has earned her Ph.D. in clinical psychology from the University of Virginia. She then completed a clinical psychology internship at Tulane University School of Medicine, followed by a postdoc fellowship in early childhood program at the Children's Hospital of Philadelphia. She currently works as a psychologist and clinical supervisor at the Tulane Infant Teen Parenting Education Program, TPEP, a program that conducts evaluation and intervention with maltreated children, biological parents, and foster parents with a particular focus on children aged 0 to 6. Dr. Breidenstine's other activities include providing psychological services to families with young children in a community mental health clinic. She provides infant and early childhood mental health training to clinicians in Louisiana and other states, and developing community programming with the Louisiana Children's Museum. Her primary interests are infant and early childhood mental health, prevention and intervention for child maltreatment and trauma, mindfulness-based interventions, resilience, and provider well-being. I want to remind everyone that we're hoping that there will be some time for questions and answers, so please feel free to type your questions in the Q&A box at the bottom of your screen, and then when the presentation is completed, I will read them to the presenters for them to answer. Thank you both Dr. Tynes and Dr. Breidenstine. It's all yours, Dr. Tynes.
Thank you, Dr. Baumann, and it's delightful to talk with you again after a number of years. As you pointed out, since we have seen each other, I'm very, the internal medicine department is near and dear to my heart at Tulane, as you know, and I'm delighted to be able to present to you. I spend most of my time in Baton Rouge now, as you said. I actually live in Lafayette. To complicate it further, a function of post-Katrina happenings, and which is appropriate for today's talk, I suppose. Even more appropriate because I live in Lafayette. We are undergoing some preparations now that you guys are spared from, I think, largely. But also right now anticipating that my 92-year-old father is getting on the road from Beaumont, Texas, where he lives, with my sister, and evacuating towards us just to be under our care. So it's a particularly appropriate topic today. Neither Angie nor I have any disclosures, and I'll get started with that. I have a lot that I would like to go over, and as I know Angie does too, and so I'll be moving along, hopefully not too fast, but Angie will be controlling the slides, and so I may occasionally need to say next slide. So this first slide actually has meaning to me because I first used it in 2005 when, as the director of the Jefferson Parish Human Service Authority, we began to do talks for public and professional groups about responses to Hurricane Katrina. And so here I am, having called up this slide now at least a dozen times, different scenarios since then, other disasters and such. But just sort of for old time's sake, I guess, for me, how do people respond or react to a disaster, particularly after? All of these things can happen in various forms, and you may have experienced them yourself, depending on how long you've been in New Orleans. Stress, and of course, but also grief. Grief is sometimes an unrecognized reaction to disaster. Family conflict, very common. Feelings of hopelessness, trouble concentrating, which is impactful for our profession, of course. Feeling just on the verge of being overwhelmed all the time, irritable, headache, insomnia, fatigue, physical symptoms such as that. After things calm a little, avoiding people or reminders of those events is common, and maladaptive responses such as the use of alcohol and drugs to try to cope is a common scenario that we find in reactions to disasters. For most people, over time, these reactions will lessen and settle down, as you may have watched or experienced. A few along the way may need some counseling and perhaps even medication approaches to help deal with that stress. Here is our disaster, however, and it is one you know well. COVID-19 resulting from coronavirus in Louisiana. This was, I think, the slide is 2 days old. We're approaching 150,000 cases with almost 5,000 deaths. You know it well. Next slide. And this is from USA Today's ongoing graphing of new cases in Louisiana. I just pointed out, really for interest, you may have seen this. Curiously, our current wave is much more than a peak, but it's much bigger than the peak, although I don't know about you, but in my scenario, in my workplace, it feels calmer actually than that smaller peak back in April and May did. Next slide. SAMHSA has published kind of a graphic of the experience we have, kind of reminiscent of the 5 stages of grief, I guess, but of a disaster, the idea of the impact followed by the heroic times, and we've kind of been through that. Most of us in healthcare are being called heroes, and we may or may not feel like that. I apologize for my chiming clock. I think that's going to happen periodically. Maybe it'll keep me on time. But followed after the disaster by disillusionment. And I think if you click the next slide, Angie, it's going to circle that. I think that the COVID pandemic may result in SAMHSA changing their perspective on what a disaster or graphic might look like. But I think there's little doubt that we're in a disillusionment sort of phase now, where we're dealing with the sequelae of the ongoing pandemic and may have to add a new hurricane to deal with as well in the state, at least parts of the state, and the impact it has both on us personally and our mental health, those of our patients, family, and friends, as well as our economy. So next slide. Morgenstein authored a white paper for the American Psychiatric Association, recently updated to reflect the COVID pandemic, the original based, I think, on the SARS pandemic, and not surprising what they found in terms of behavioral and psychological impacts, symptoms such as fear, uncertainty, feeling of being unsafe, even scapegoating at times, increases in physical symptoms, lack of energy, fatigue, aches and pains, those sort of psychosomatic symptoms that sometimes motivate us to seek medical resources in higher rates than we would normally. Once again, increased use of maladaptive responses like alcohol use and drug use to cope. In the general COVID scenario, you're well familiar with these stressors, but they're worth delineating, I think, for no other reason than to see how many there are, whether all of them have affected you, or perhaps realizing that your patients frequently have many, if not all of these. So the stressors of having to shelter in place at times, especially early on, was stressful, but we still have this issue. Quarantining, of course, still a prominent way of dealing with trying to contain the spread. Isolation that results in boredom from that. I always like to include this because it's so counterintuitive, but increased family time. We always find ourselves wanting family time, wanting to say, well, if I could work from home more, it would be great, wouldn't it? Now we have that. Be careful what you ask for is kind of the moral of this. It's a very prime mover in stress. Fear of infection, of course, or infecting others. Not enough supplies for just general purpose, general hygiene, but also in our case, of course, PPE and other related supplies. Job and financial loss for many, many, many of our patients and family, perhaps, and friends. A significant stressor. Difficulty accessing medical care at all or accessing it in your usual fashion is quite a stressor. Inadequate or inconsistent information, whether it's from national leaders, state leaders, our own healthcare system and our own healthcare machine, if you will, CDC, whatever, with trying to apply information to our daily lives can be very stressful. And of course, fear of the illness consequences and death. Next slide. So a couple of months ago, the Kaiser Family Foundation published one of their surveys, this one of over 5,000 Americans. This may not be surprising, but it helps us begin to sort of narrow the focus of the stress that I'm talking about. The percentage of adults you can see here who say that worry and stress related specifically to COVID has had a negative impact on their mental health to the tune of 30 to almost 50% of the population surveyed, with about a third of those numbers reporting that it's had a major negative impact in terms of anxiety, depression, other things in their mental health. Probably more so in those that are having to shelter in place and quarantine, as I mentioned a minute ago. Next slide. From the same survey, it's interesting to see the same 40 to 50%, of course, negative impact on mental health, broken down though by household income, producing, a graphic that reinforces for us those that have tighter margins on their financial resources, the inability to absorb not working for a couple of months, the inability to go beyond their usual circle to find needed supplies and such, or have the resources to pay more, whatever it is, to get those things, and tolerate quarantine and not working, and those things seem to be impacted almost twice the rate of those with higher salaries. Next slide. The American Psychiatric Association commissioned a similar survey, over 1,000 Americans, which really confirmed this. As you see the numbers, 35 to 50% reporting significant impacts of COVID on their anxiety about getting the virus, giving it to others. Are there significant others getting it from anywhere? Anxious about dying from the virus. And as we saw in the Kaiser data, reporting significant impacts on mental health. Next slide. Just in the last week or so, the CDC has published this MMWR, another similar survey that had an interesting twist, so I wanted to just briefly mention it. Once again, over 1,000 recipients responding. The anxiety and depression reported symptoms at 31% represented 3 to 4 times that in a similar survey reported a year ago at the same time. Suicide being double the rate of a year ago at the same time. The trauma, you see the graph around trauma, at 26%, 1 in 4 patients reporting at least some trauma-related symptoms around COVID. That is specifically around COVID, although it doesn't say it there. And those that have either started using substances, alcohol and drugs, or increased their use as a result of their stress around COVID at 13%. Sort of very staggering numbers. Next slide. This was just a screenshot. I could have put the journal up. This was the results of a survey in the Journal of General Internal Medicine, published in the spring, the Journal of General Internal Medicine. Just so we've seen data that the stress is significant. I'm sure you're convinced of that now. The 5 things that the general population reported, number 1 being just reading and hearing about the severity and contagiousness of COVID-19. It's one of those approach avoidance issues that we all have and can translate into perhaps some intervention if you're a person that can't just tear yourself away from this sort of thing. But just reading and hearing about it, almost 100% reported that being a top stressor. Uncertainty about the length of quarantine and social distancing, which impacts all those things, family, social events, economic drivers, that sort of thing. Changes to the social routines, you know, vacations, well, that's actually number 5. And other daily social things, being out with family, being out with friends, and others. Changes to daily personal routines, just how you cook, what you can get, the supplies, how you do your cleaning has dramatically changed and may never be the same, right? Exercise and relaxation activities impacted. That's number 4. Number 5 is the special celebrations and events, weddings, vacations, special entertainment, that sort of thing. Those are the top 5 from the general population. Next slide. So I couldn't not, as a psychiatrist, I could not mention the impact on the mentally ill. We are also seeing probably through a couple of these stressors, and that's the loss of chronic maintenance treatment. The loss are a dramatic alteration in how you receive your chronic treatment for those who have chronic illnesses that must continue to have doctor visits, or visits by assertive community treatment teams that go out to the house, that sort of thing. All of that's changed and disrupted lives that were already, in many cases, fairly chaotic. The challenges of trying to get the help you need by video visits, we have that in people who don't have mental illness. Fear of contagion itself, sadly, presenting to the emergency department for some is their primary way of getting their medications or getting at least acute illnesses or subacute crises taken care of, and that has dramatically reduced, as well as fear of contagion in the pharmacy. We have seen the ED numbers drop of our patients presenting there, and it's been quite concerning. Our patients with severe mental illness are prone to isolation and its devastating side effects, and this, of course, is a purposeful isolation at times when you need to quarantine or stay away from others. Very stressful. There may be specific impacts with people who already have anxiety disorders, depression, OCD, PTSD, or I'm seeing some data on eating disorders as well. Next slide. An impact on the medically ill, the medical presentations that you see outside of just having COVID itself. We are seeing many cases of delirium, which are encephalopathy, which appear directly related to COVID. New psychiatric syndromes, meaning new for that patient. Depression where it never was before. Psychosis where it never was before in patients. Mania in patients that have never had manic depressive sorts of symptoms before. Some medications produce psychiatric or neuropsychiatric side effects. We're not using hydroxychloroquine and related drugs as much, of course, now, but that can be an issue. And I couldn't help but also point out that, interestingly, some data out of China from the SARS outbreak, the earlier coronavirus that we didn't have an acronym for, perhaps, an early COVID several years ago, some data in Hong Kong, I may have said China, in Hong Kong, following patients that had the disease, survived it, and were reevaluated over time. 4 years later, 40% basically showing a diagnosable psychiatric illness, clearly higher than the general population, and cause for very sober evaluation now as with what we face with COVID-19. Next slide. This slide I had pulled for earlier talks at the end of May. This is an NPR slide. It was just a dramatic reminder. At 300 deaths of healthcare workers, that data has at least tripled now. We know that as healthcare workers, particularly frontline workers, there is this undeniable element of danger in what we do in our exposure. Next slide. in compiling from different resources specific sources of stress for healthcare providers. Obviously, there'll be overlap with the stressors in the general population, but I wanted to mention those, obviously fear of infection, but also fear of infecting your family. One of the number one stressors that I hear about are just separation from family and the stress that that brings in order to prevent bringing illness home. Stigma and avoidance by others. I saw one person's testimony that it was odd that at work I'm a hero, and then I go to the grocery store and I'm a pariah. Nobody wants to be near me. I might have have virus on me or something. The worries and stress about the patient surges or sometimes lack thereof. We've had interesting experiences in the ED where our numbers are dramatically lower than they were a year ago at the same time, yet the intensity with COVID, particularly during those peak times, can be very stressful. Worries about PPE, of course, and the difficulties for caring for patients when you're dressed in a bubble suit. Managing the distress, not the illness stress, not the illness itself, but the distress of patients who may not have available their usual support system, family members particularly, who would all be in the room with them in a normal, if you will, illness. The isolation that it's brought. And in some cases, you, of course, may have experienced or heard even isolation and death. Staff shortages brought about either by people not wanting to work in the environment or having the illness themselves and not being able to return. Feelings of inadequacy in handling everything coming at you. Grief, once again, a big picture in any disaster stress reactions, and the changing and inconsistent information we mentioned before. Next slide. So I also couldn't pass on a recent article that I saw, Alina Maymine from a hospital system in New Jersey, writing about her experiences dealing with, she is a psychiatrist, but dealing with residents of all specialties, and some of her top stressors that she deals with in that work is stress of having end-of-life discussions, particularly for early residents, and particularly with the frequency that COVID has demanded. Sometimes even doing that remotely, which is something we've virtually never done before. Some non-emergency or ICU residents may at times feel like they're not contributing enough, almost like an imposter syndrome. Why am I here? Why am I being called a hero? I'm not doing nearly the work that some of my friends are doing in those environments. Some may feel they're burdening their peers if they go out on sick leave. We always deal with that some, right? But this is one where no questions, you cannot come to work like that. Are needing special consideration because you have an underlying immunocompromised state or pregnancy or something like that that is a concern, and that stress of burdening your peers. Next slide. I'll point you to one of your favorite magazines, ACP Hospitalist. Does have 10 wellness tips. I'm going to flash up here, common sense wellness tips, things that you can do and be aware of. But I will also mention on their website, they have an entire resource that goes into much more detail, so don't forget that that's there. In their top 10 things, being flexible. Obviously, information changes, protocols change, rules change. We have to be flexible even more than in a normal situation. And just being prepared for that may help relieve stress. Stay connected to others, family and friends, for sure, but perhaps even colleagues in a way, even if it's virtual, in a way that keeps you from isolating. Be informed, listen, read, but don't overdo that. Be aware of your of tendencies to want to just continue to absorb and the negative impact that we know that has. Be empathetic, both with patients and their situations and their distress, but don't forget your own peers, and even family who's dealing with the stress of what you do, perhaps. Recognize what's in your control, and obviously take control of that in the way that you normally would, but probably more importantly, realize what's not in your control. You can't cure this virus. You can't change healthcare systems or the way they must approach whatever, PPE, other, distributing of resources, whatever. Get creative in how you address problems. Problems with isolation have been addressed by, tablets to talk with patients. If patients have a strong connection to their faith, having ways of talking with their pastors while they are on isolation, things like that, and celebrating patients who are able to leave the hospital. All of those are things that are creative but can be uplifting and help deal with your stress. Reflect on your purpose when things get difficult. Remember why you went into this, what makes you tick. Remember times when you had that inner sense of energy and purpose and joy in what you did, even though right now may be stressful. Stay positive that this will pass and we'll get past it. Take care of yourself with exercise, eating right, stress reduction. Talk about that a little bit in a minute. And connecting with your own resilience, all those times where you had self-talk, whether it was the first time you took, the USMLE, or the first time you took your boards, all those things were, first time you did the ICU rotation, all those things where we've been through it many times. I mean, it perhaps was a shorter term and this is a longer term. Remember, you've made it before. You can make it through this, and this will pass. Next slide. One of my social workers also created some to-do list of things you can do in your routine to try to reduce your stress. Develop and adhere to a new daily routine. I say new because it may, of course, not be the same. Stick to that sleep schedule. It's critically important. If you're a person that exercises, continue to do that as much as you can. Mindfulness can be helpful in the moment, real-time stress reduction, and there are ways of getting that. We'll talk about that. Spend time outdoors, particularly if that's something that you enjoy doing. Just taking a walk gets you out in the fresh air. It can be a distraction, might even be a connection with neighbors and such at a distance, of course. Stay connected with friends and family, even if virtual, as I mentioned before. Limit that time watching the news. We talked about that. Stay healthy in a diet. Enjoy, try to engage in the activities that you're still able to do. When you're not working, try not to bring that work home with you. Rely on your faith if you're a person who has a strong faith and connection to your church, and seek professional help if you need to. Next slide. I wanted to mention briefly, I'm going to run out of time if I'm not careful, but in one of my recent talks, we had it was a talk, but it was also a hybrid with a memorial for some of the healthcare workers we had lost in the hospital in Baton Rouge. And I was asked to talk a little bit about that grief thing that I led out with, as sometimes an unrecognized stressor in a disaster. This was also an APA, American Psychiatric Association, white paper on the major points of consideration for both professionals and for evaluation and self-therapy, if you will, for going through grief in this sort of context. Understanding and accepting grief, that it is a normal part of an abnormal process, an abnormal event, that it does pass, and that you can work through that, managing that emotional pain by also not failing to remember those positive aspects of either a person you've lost, maybe it's patients that you've lost, or maybe it's even a thing. Perhaps it's a group of providers that have always worked together, but this has changed things. It's a unit that's always worked together, but it got split up because of the needs of the COVID. It's a program that you think may never, gel again and come together. Grief can be any of those things. It can be personal stuff, it can be professional stuff. But remembering that there's a positive side to that story. If you're grieving it, it's because you loved it. If you're grieving it, it's because you love that person. And so there's a larger story, and that this endpoint is part of that larger story, but it's not all of that story. See the possibility that because those relationships or those things happened before, that some version of that will happen again, and perhaps even something good come of what you're going through now. Strengthen those relationships with others. Listen to other people's stories and let them listen to yours. This is not the time to take score. You spent more time with me than I did with somebody else or whatever. Let people help you. Let people listen to you, and then be that person that listens to someone else as well. Just that can be stress relieving. Coming to terms with the story of the death was in this particular list because of all the stories of COVID deaths that have such heart-wrenching details about them, people that died alone without their family, young, healthy people that shouldn't have died that did. All of those things that may be part of your story of grief coming to terms with that, but again, realizing where it fits in the bigger picture, what we can control and what we can't control. Eventually, in grief, we frequently get to the point where we're not wanting any reminders. We're not wanting to go around people or places that remind us. Some of that we can't avoid in this context, but eventually, as you work through this, you will want to try to expand your perspective on those. Begin to let some reminders back in. For instance, a tiny thing is that very first slide I opened with. As I said, I included it because it was a reminder to me of a pretty hard time with post-Katrina. Yet there were many good things that came out of that, despite the bad things. I had relationships, and there's been programs and other things that have happened because of Katrina that wouldn't have happened. So it is a mix, and it's to me, it's like one of those little reminders that I thought about when I was putting this all together. Remember, lastly, that your connection to the memories of the deceased are the thing that you've lost, program, a unit, whatever, a group, that your connection to them does become embodied in your memory. Your connection is not gone. You're connected to the memory of that person or that thing, and your memories don't have to be painful in that regard. They can be pleasant and positive and uplifting to you as you think back over the entirety of that relationship. Okay, next slide. So in continuing to talk about things you can do, I could not fail to mention Tulane's resources. I'm really hoping that you've seen all of these things coming through on email or other resources. We can get these to you easily. These are both in-house possibilities and some community possibilities. The very first one is the virtual group gathering, which I'm going to ask Angie to talk about in I hope 30 seconds to 60 seconds, and her work, really interesting work in providing that service. And on the very bottom, don't forget that you have an EAP. Next slide. It turns out that the EAP for Tulane is the same one as Our Lady of the Lake, and there are a lot of resources there. I'll point out one on your list. It's called text messaging, and in our resource, I think it's called Talkspace or something like that. But it's the ability to text with someone who can sort of be a sounding board or even provide some counseling by text on and off during the day. Very flexible, very available, and everything else in between. It's all confidential. Don't forget that that's there if you're feeling stressed. Next slide. I also didn't want to fail to make you aware, if you haven't seen this, there is a national physician support line that's created by volunteer psychiatrists, open 7 days a week, almost all day. I think it closes at 1 in the morning. But they are available to talk to you about anything. But they were created in the context of healthcare providers in the COVID era. Next slide. And lastly, of course, some of you, or maybe most of you, work in the VA. You may be aware of mobile apps. There's many of them out there. I think there's Headspace. It talks about that helps you walk through mindfulness activities. I just kind of like the idea of this one. The VA makes this publicly available. It's a COVID coach that has, once again, tons of resources for daily stress reduction. And information about COVID and all that kind of thing. I wanted to make you aware of out of the National Center for PTSD. And with that, next slide, I think I'm going to ask, oh, yes, and if your stress and distress reaches crisis levels also, and you're, for whatever reason, unwilling, unable to go with local resources, don't forget there are national resources for the Stress Helpline and national suicide prevention. And also the suicide prevention line does also have a talk and text counseling line, which I find wonderful. I just got the pop-up message. I'm at the 30-minute mark, which is where I'm supposed to be. I can't believe it. I made it under the wire. Now is the point. I'll ask Angela to take it from here and tell us some about her really amazing work with providing video groups. Angie?
Thank you, Lee. I appreciate that. So we all know, of course, as Lee's been talking about, that the COVID-19 crisis has brought about substantial workplace challenges and changes for healthcare professionals. And in many cases, it has brought heightened stress, new uncertainties, grief, and shone a spotlight on human vulnerability. So I'll be sharing an overview of one way that the Tulane School of Medicine tried to offer support to our healthcare professionals. Before I go further, however, I just want to take a moment to express appreciation for all of you providing healthcare services for our patients and our patients' families and community. There really aren't adequate words to say thank you for your work and your courage and sacrifices, but just know that we are very grateful. So thinking back a bit, we all remember in March of 2020, we received the stay-at-home guidelines here in New Orleans as the COVID-19 cases were rising. And the Tulane health system was actively and proactively engaged in providing care for patients, in responding to what was known about the virus, and in preparing for what might be coming next. And at that time, Dr. Thompson, who is the head of Psychiatry and Behavioral Sciences in the School of Medicine, began asking how could our department, which includes psychiatrists, psychologists, and social workers, provide a supportive resource for our faculty and trainees in the School of Medicine during the COVID-19 crisis. And he communicated with Dean Ham about this possibility, who was immediately in support of the idea. Dr. Thompson then reached out to Dr. Julie LaRue, who's the head of psychology in our division, and discussed the possibility of providing some type of virtual groups. And a team of us started thinking about what might be feasible and what might be helpful to our medical colleagues. So we wanted to create and roll out something quickly under the circumstances, and our question then became, what should a group like this look like? So as we started planning, one of the first issues we thought about was how to offer something that would be practically and logistically feasible, given the schedules and workloads and pace of work in the medical setting, especially during the pandemic. We wanted to offer something that would be beneficial without being time consuming. So we decided that the group should be a standalone group so that someone could find time to attend one and receive the content and the experience without having to attend multiple times. And given the pandemic, obviously we knew we would provide the group by Zoom. We chose to structure the group as a workshop that would be led by a faculty member or a faculty resident combo. And we created a PowerPoint slideshow with the workshop curriculum and with a guide for the presenters, so that the same content and experience could be delivered by any of the group presenters or leaders. We decided to structure the workshop as a combination of sharing information about stress management and guiding participants in experiential exercises. And the group model that we put together differed in a couple ways from some other types of groups that are sometimes offered. We decided that we wanted something that was more experiential and more participatory than kind of a traditional self-care didactic that went over strategies for caring for yourself. And in contrast to that, we wanted the experience of the workshop itself to provide moments of relaxation and chances to practice methods and try out different methods for supporting oneself. Our group model also differed from a support group or a processing group model, which is when you provide an open format for participants to discuss their thoughts and their feelings and experiences and support each other with facilitation from a group leader. And we felt that the support group model wouldn't fit well within our constraints of this group. We wanted to offer, again, something that was standalone group, and doing a support group would be difficult with having an unknown number of attendees, different people each week. We also felt that a support group would have the potential of increasing stress for certain participants if they were witnessing or hearing reports of stress and distress or traumatic events from other participants in the group. And we also know that encouraging people to debrief in the midst of a crisis or right after a trauma does have the potential to be harmful. So for these reasons, we decided to refrain from kind of a group discussion format and instead offer a space where we would provide the content and we would guide supportive experiential exercises. And we allowed some space at the end of each workshop in case anyone participating had questions or comments that they wanted to share with the group leaders. The quote here by John Kabat-Zinn comes out of mindfulness traditions, but the concept here is also foundational to what is known as third wave cognitive behavioral therapies, which include a focus on how we process and how we relate to our experiences that come our way. So this concept served as one of the focal points for our workshop content. How can we learn to surf or respond to the stress, uncertainty, and emotional challenges that are present in times of crisis? What are things that we can do to support our resilience? We ended up naming the group Surfing Practice, reflecting this underlying principle that change and experiences of suffering are inevitable parts of life for all human beings. And that one thing that can help us during difficult times and during good times is to find ways to accept change and to work with the reality that is coming our way rather than fighting against it. So it's kind of like a car leaning into the curve or a surfer riding the ebb and flow of the waves. When we fight against painful realities by holding tightly to the wish that things were different, we often end up feeling worse and even suffering more. So working on accepting the challenges and pain come our way simply because we're human can lessen some of the suffering we feel, while we also focus on doing whatever good we can for ourselves and those around us. We decided to make our group a 45-minute Zoom gathering, and we offered it multiple times a week at different times of the day to try to make it as accessible as possible. And as I mentioned, we created a set of PowerPoint slides and experiential activities for each group leader to use. We also wanted to reduce any self-consciousness that people might feel about joining the group. And so when we publicized it, we announced that participants could turn off their cameras and join anonymously if they wished. So something that is worth mentioning here is that we planned this group with no illusions that it would be some magic bullet to resolve stress for everyone who attended, or for anyone who attended. One of our hopes for the group was that it might help normalize some of the things that Lee was talking about earlier. Normalize the fact that healthcare professionals, like others, are going to experience strain and times of exhaustion, emotional upheaval, and ups and downs during this time of crisis and chronic stress. So it's not to say either that the only thing we will experience are difficult emotions. During the crisis, we might also have feelings of satisfaction for helping a patient. We may feel energy for the tasks in front of us, or fulfillment for living in accordance with our values and work that we find meaningful. But we also know that competent, high-achieving people, like everyone on this call, usually expect a lot of themselves. And it can be easy for people to underestimate how a significant and cascading and ongoing crisis like this affects us. Whenever we're thinking about stress management, it's also important to think about the fact that every person's situation is different. So for each person who entered this pandemic situation, we are carrying our own histories and our own realities. So maybe one person's history includes a recent personal loss, or someone else's reality might include a chronic medical condition that makes them more vulnerable to COVID-19. Or perhaps my colleague's life already includes having to deal with stressors of racism. Or one of the staff members in my clinic is struggling financially because his spouse was laid off at the start of the pandemic, similar to what Lee mentioned earlier. We also know that people of color are disproportionately affected by COVID-19, such as African American, and according to a CDC report I just read, Latino persons in the United States. And we know that Asian Americans have experienced increases in racism during this pandemic. So all to say, we are all being affected, and yet we know that people are being affected differently by the pandemic in different ways and at different times. So it's helpful to remember for ourselves and others that any stressors, challenges, or trauma that each of us was carrying before the pandemic started is relevant to our well-being, our reserves, and how much capacity we have available to carry more at any given moment. We've probably all felt like this poor donkey at times, being overloaded, but I don't want to sound discouraging because there are absolutely things we can do when faced with adversity and being overloaded by stress, things that can add to our well-being bit by bit. And we try to incorporate ideas and information from what we know about how we can support our resilience into our group curriculum. So as I touched on, the group curriculum was generally structured to, 1, share some practical ideas for coping with stress, including brief reminders about self-care practices. 2, to guide participants in experiential activities designed to be calming and beneficial. And 3, share strategies for enhancing well-being. We also wanted the experience of simply attending the group to be restful and calming. So from this short group workshop, we hoped that people might experience and identify some strategies that they would carry forward with them when the group was over. So on the screen here, you'll see an outline of some of the main focus areas. During each group, we spent some time recognizing and validating the experiences of stress and emotional reactions to the challenges of COVID-19, both professionally and personally. And while recognizing that these might be aspirational goals for many physicians during the pandemic, we briefly reviewed the value of trying to attend to things like adequate sleep and nutrition and exercise and tuning in with our social support, and some of the other tips that Lee mentioned earlier. We also briefly reviewed some of the principles from mindfulness and third wave CBT traditions. So in addition to what I mentioned earlier, ideas like being able to recognize when we're engaging in unhelpful strategies like catastrophic thinking, being able to focus on what we can control in the midst of the pandemic while acknowledging that there are things outside of our control, and being in touch with our common humanity, which is knowing that pain, disappointment, and suffering are universal shared human experiences. Remembering common humanity can help reduce feelings of isolation or inadequacy during difficult times. So we interspersed these reviews of information with guided experiential exercises, and we drew exercises from mindfulness traditions and from a curriculum on mindful self-compassion. And we also drew from positive psychology. We selected some activities that are specifically designed to help calm the body and quiet the mind. So we introduced the activities as invitations for participants to try, with the caveat that anyone should disengage if they found that a guided exercise was uncomfortable for them. And just to mention, we know that different people resonate with different types of exercises and activities just by virtue of individual differences. And we also are aware that guided mindfulness-based activities can end up being uncomfortable for some people based on their particular history. So for example, an exercise that focuses on deep breathing could be uncomfortable for someone who has asthma, or for someone who has had COVID-19, or maybe is working with patients right now. Or doing a body-based experiential exercise has the potential to be uncomfortable for someone who has had an intrusive physical trauma. So we tried to offer a range of experiential exercises with the suggestion that the participants view them as experiments to see what might resonate and feel helpful to them personally. Each activity was relatively brief given the time constraints, but we tried to make them long enough for people to get a taste of whether a particular strategy or practice might feel helpful to them. We also drew on research on personal practices that enhance well-being, such as gratitude practices. And as part of creating just a calming and hopefully enriching 45-minute group, we shared photos of nature, some poetry, some quotes as part of the experience. And at the end of each group, we included a slide with resources for more supports, such as therapy. So I'd like to give you just a few illustrations of some of the types of experiential exercises. For example, we shared information about the practice of savoring. And savoring basically means making a practice of noticing good things around you and then bringing your attention to them, and when possible, taking extra time to linger with the experience and intensify your enjoyment of that moment. So savoring is really a way to make an enjoyable experience register with us and last for as long as possible. There are many different types of experiences that one can savor. It might be choosing to turn away from the computer for 2 minutes while you eat the orange that you brought with you for a snack. So you are focusing on the feel of the fruit and the texture and the flavor instead of multitasking during those few minutes. Or it could be closing your eyes and listening intently to 5 minutes of your favorite music, or stopping on a walk when you notice a flower and taking a moment to really smell and notice and appreciate the details. So during our group, we explained this concept and we invited participants to spend a minute savoring something enjoyable. We offered them this photograph, or we allowed them to choose something in their environment and use this as an exercise to experience that practice. One of the interesting research findings that we also shared is that to bolster our overall sense of well-being, the frequency of pleasurable experiences is actually more important than the intensity of those experiences. So it really is beneficial to add brief, small pleasures to our daily lives rather than postponing and waiting for pleasurable moments until we feel like we have time for a long break or a real vacation. So we also included a gratitude exercise in the group because research shows that gratitude practices enhance well-being. The practices can lower blood pressure, improve immune function. Gratitude practices have been found to reduce the lifetime risk for depression and anxiety, and gratitude also affects behavior. So for example, studies have found that grateful people engage in more exercise, in better diets, and are less likely to smoke and abuse alcohol. So for this exercise, we invited participants to think about and write down 5 specific things that they experienced in the previous week that they felt grateful for. And when doing this, we explained that it is helpful to think about something specific and to write down some details, although in a brief format. Being specific helps us to visualize what we're grateful for and to really connect with that feeling of gratitude more clearly. And the practice can include things also like writing down dodged a bullet moments, so meaning things that we avoided that were negative, or maybe thinking about how our lives might be different without certain things. So the practice really helps to reveal things that we take for granted, sometimes more than we realize. So we allowed each participant to work individually on their own gratitude lists for a bit. And then we followed that with a moment of reflection, just to tune in and see whether that practice resulted in any immediate effects on participants' feeling states. And then we wrapped up each group with some reminders of things that we had reviewed or practiced, and invited participants to set an intention for maybe something they wanted to incorporate into their lives in the coming week, and to jot down anything specific they wish to remember. So as I mentioned, we originally offered the group to faculty and trainees in the School of Medicine 4 times a week starting in March. And we were invited to offer it in more broadly. So we offered it to HCA, including staff, and also to staff in the School of Medicine. We received interest from groups in the community, some of our partners, and we ended up offering it for people at Crescent Care, at the Louisiana Office of Public Health, and also at ELMS. So we're now offering the group less frequently and live, but the next scheduled group is actually tomorrow morning at 8:30 to 9:15. So if anyone wants to join, you'll see the link there, or you can email me to receive the link. I'll be happy to email you back. And we also have a recording on Box that anyone can access at any time to view it and participate in the activities at your leisure. I just want to acknowledge the group of people who helped put this together and led the surfing practice groups over the last few months. And one quick mention, thinking about the future, that there's a relatively new 6-hour evidence-based or adaptation of an evidence-based mindful self-compassion curriculum. It's designed specifically for healthcare professionals. It aims to improve well-being and personal resilience for healthcare professionals by teaching mindful self-compassion skills to deal with distressing emotional situations. And initial research is finding that healthcare professionals report decreased depression, stress, secondary traumatic stress, and burnout, as well as increases in self-compassion, mindfulness, compassion for others, and job satisfaction. And it's a group I just finished my training in, and maybe at some point in the future, there will be opportunities to share it with the Tulane community. Thank you.
I want to thank both Dr. Tynes and Dr. Breidenstine for this wonderful presentation. Dr. Breidenstine, I must mention that I found your slides therapeutic. Thank you. We have just a few minutes maybe for one or two questions. I think there is a thank you note to Dr. Tynes from Dr. Mayo Twin, but I don't see any other questions. We'll wait for a couple of minutes, see if there's any questions. Well, it looks like there are no questions. I want to thank you again very much for this wonderful presentation. And Dr. Tynes, good luck with the hurricane. That sounds really serious, unfortunately.
Yes. Thank you very much.
Okay. And
thank you very much.
Thank you.
All right.
Bye, everyone.